Hello, my name is Amber Alvarez, and today I will be doing a general head to toe assessment of the newborn. And I'm going to direct the camera angle to be able to see the infant, and you'll be able to see all the motions and assessments that I'm doing. Okay, here we go. And before we do the head to toe assessment, I would have reviewed maternal history and, of course, infant history too. Alrighty, and then we would wash our hands, identify the correct patient, and then begin the assessment. So while the infant is nice and quiet and hopefully calm, that's when I would assess the heart rate, respiratory rate, and bowel sounds. Normal heart rate can be about 140. A term infant may have a heart rate of about 120. We are also going to assess for bowel sounds, and the bowel sounds should be active unless this baby is NPO or brand new. That can have an impact on the frequency of bowel sounds. Simultaneously, I'm also assessing the baby's neurologic status, so just seeing the activity of the baby, the tone of the baby, the reactions to the hands-on assessment. But we'll go into further detail in just a minute. So first I'll assess the heart rate. Assessing the heart rate, and then of course I would stay quiet for the entire time, but for this purpose I will explain what it is that I'm doing. So I'm assessing not only the heart rate, but also the heart sounds, making sure that everything is normal. So we're hearing the first and the second heart sounds. I'm not expecting to hear a murmur. If I do, of course, I'll intervene with that as appropriate. I am also searching for extra heart sounds or diminished heart sounds, just trying to see how the heart is sounding and the rate. So next I would move on to the respiratory rate. So I'm assessing respiratory rate and clarity, so I'm expecting for the lung sounds to be clear. I'm also going to assess for bilateral breath sounds, so seeing if both sides of the chest sound equal and the same, and seeing if all the lobes sound clear. So I'm not searching for, or I'm not expecting to hear crackles or coarse sounding lungs. I'm also assessing respiratory effort, so searching for if the infant has any retractions here, so subcostally or substernal, suprasternal, intercostal retraction. So just looking at the work of, like I said, hopefully the infant is quiet at this time. I would then assess the bowel sounds. So I'm going to assess all quadrants of the bowels. And of course I'm looking at the infant generally to see the shape of the abdomen, making sure it's nice and soft. So now that the infant is okay to become more active, because I'm not dependent on what I can hear from my stethoscope, I'm going to begin my head to toe hands-on assessment. So I begin by looking at the head or the skull and seeing that it is symmetrical. There should not be any flat areas to indicate brachiocephaly or plagiocephaly, for example. I'm also assessing the hair distribution and the texture of the hair. I'm also assessing the sutures along the infant's skull, along with the fontanelles. So the sutures can be separated, approximated, or overriding, and hopefully they are not fused at such an early age. The fontanelles should be soft and flat. The anterior fontanelle is typically larger than the posterior fontanelle, but I'm assessing for both, so that's what I'm looking for there. I'm also going to assess for any type of lesions along the scalp, and I'll assess the back of the scalp more when we turn the infant over. So assessing for lesions, abrasions, scaly patches, anything abnormal on the skull. I'm also looking for eye symmetry here, and sclera should be white or like a grayish color, depending on the term of maturity of the infant. The pupil should be reactive to light. There should also be a bilateral red reflex present. On a normal healthy newborn assessment. Eyes should be reacting to light, which I mentioned. The nares should both be patent, and the nose should be symmetrical and midline in the face. The mouth should be pink and moist. The chin should be appropriately placed out here. And like, for example, this infant has a normal chin. I would be aware if the infant had a chin that is placed back to, for example, the micronanthia. So that may indicate some abnormalities in the infant's physical well-being. Of course, soft palate. So my finger would go inside the baby's mouth. Bilateral ears should be symmetrically placed. They should also, I would not expect them in a normal newborn to be low set. So these ears do appear normal, so the ears are not somewhere down here, which can indicate some anomalies there or abnormalities. The shape of the ear should appear normal, like this baby's ear, on both sides. I'm assessing the cartilage. They should fold in and then turn right back to their normal position if this is a term newborn. I'm also searching on both of the ears for any skin tags or abnormalities with the ears. If there were some abnormalities, we may want to do a renal ultrasound and just follow up the general follow-up to see if there are any anomalies going on, along with maternal history and then fetal diagnoses. I'm also going to assess the back of the ears to make sure there's no breakdown, especially if this infant is in the neonatal intensive care unit. Sometimes these babies have oxygen, and the oxygen can keep their ears flush to the skull there. So I'm assessing for breakdown in the backs of the ears. I'm also looking at the infant to see the symmetry of the facial movements. So baby's face should move up and down with a cry or activity. They should not have one-sided drooping and the other one reactive. So that's what I'm looking for there. I'm also going to work my way down, so the neck folds should not have any breakdown. There may be a little bit of vernix if this is a brand new infant. And excuse me, I'll just mention again, while assessing the palate of the infant, there should be a sucking reflex along with a gag reflex there. So the neck, like I said, should not have breakdown. I'm also assessing the back of the neck. There should not be any excessive skin folds back here. So this baby does have just normal newborn skin here, but nothing excessive. The clavicle should be intact. I should not feel any crepitus when palpating the clavicles. The infant should not present with any pain, which could indicate a fracture of the clavicles. The clavicle fracture can also be manifested by unilateral movement of the infant's upper extremities. So one extremity may be up like this, and the other extremity is just down. So I'm assessing for the pain in the clavicles and simultaneously looking at the movement in the arms. The movement in the arms should be bilateral, as I mentioned. This infant, as I previously mentioned too, the tone of the infant is also assessed. So a term infant is going to be here in a flexed position versus a preterm infant is going to be in a more relaxed state of physical tone here, just like this baby is presenting. I'm also looking at the skin of the arms and making sure that there's no rashes, and if there are, they're normal. I'm going to assess the brachial pulses, making sure that they're equal and bilateral. I can also assess the radial pulse here, depending on if that is a normal, making sure that that feels nice and normal. We can also assess the hands, so I count each finger to make sure that there are only 10. And if there are any extra digits, we can see if that's a familial tendency or if that's something else that we need to look into. The baby should also have a palmar grasp here, so they should grasp my fingers when I'm holding the hands. I'm also looking for a semi-increase on the across the palm on both sides. If there were a semi-increase, that may indicate a genetic anomaly. For example, Down syndrome infants can have a simian crease there, so the crease just goes right across the hand. While I'm assessing the hands of the infant, I have the arms in my hands here, so that's when I would check the tone too. Even though we're already looking at general tone, that's when I would look at the tone. So I would lift the baby just a little bit to see a head lag. So typically the baby's head would lag this way, and then I would gently push them down. So I'm just making sure that the baby has normal tone. If the baby has an extreme head lag and they're not extremely premature, they can be considered hypotonic. If they have no head lag, like for example, this doll has no head lag at all, and the baby may be considered hypertonic. So that's just an assessment there. And I would intervene as appropriate. We have assessed respiratory status, as I mentioned earlier, but I'm also going to look for symmetrical chest rise. The precordium here, this should be quiet, so I shouldn't see the heart beating outside the chest. Very premature infants do have thin skin and a lack of body fat, so sometimes you can see their heart beating here in the chest. But in a normal, healthy term newborn, you really shouldn't be able to see a lot of the chest heart rate there. Simultaneously with everything, as I mentioned, we're looking at the skin, the color, and the overall appearance of the infant. But we continue to work our way down, and the sternum should be just level with the ribs. It may be concave inside, so that might be pectus excavatum, so we're just aware of that. I'm also going to assess the abdomen. The abdomen should be soft and round, as we mentioned earlier when we did the bowel sounds. And I'm also going to look at the umbilical cord. So if this baby is very new, I'm going to assess the umbilical cord, see if there are 2 arteries and 1 vein. I'm also, depending on how old the infant is, if the umbilical cord is healed, I'm assessing for umbilical hernia. I'm also going to palpate the abdomen. Babies should not have any significant pain upon palpation. The liver can also be felt here in this general area. I'm going to then look at the lower extremities and assess symmetrical movement and tone. I'm also looking at the skin of the legs along with the feet and the number of toes, so there should be 10. I'm also going to look at the colors of the tips of the toes along with capillary refill. So it should be less than 3 seconds. It's typically only 1 to 2 seconds on these infants. If this baby had a central line in the umbilicus, I would also be very concerned, just like we would for any newborn, on the capillary refill and perfusion to the lower extremities. So making sure that everything is pink here is very important. I'm also going to assess the hips, so I'm going to do the Ortolani and Barlow assessment. So I'm going to put, excuse me baby, I'm going to put my hands here and be sure that while I'm assessing the infant, I'm not feeling any cracking or popping sensations. The infants typically don't react with any type of pain when I do this assessment either. Another side note is that the infant may have a lot of creases all over the sole as they are approaching a term gestation. A preterm infant would have more of a smooth foot. Alrighty. I like to open up the diaper last, so I don't open it up until after I'm done assessing the back of the infant, simply so I don't dirty my hands. When I do open the diaper, I will assess femoral pulses in the genitalia. So now that we've done a front assessment, I'm going to turn the baby over and gently hold my hand here on their face and their chest, making sure not to occlude the airway there. And this is when I would do a more detailed assessment of the stool, being sure that I'm checking everything that I checked earlier. So fontanelle, sutures, lacerations, shape of the head, behind the ears, neck folds, and this gives me just a good view here of this ankle. I'm also going to assess for the spine here and the color of the back. So the spine should be nice and straight as we run our finger down. There should not be a tuft of hair on the bottom or a sinus tract. Occasionally, the baby will have Mongolian spots here in the upper buttocks, so you can pull the diaper down and you may see the Mongolian spots there. And then depending on the size of the baby, sometimes you can open up the behind here and see if the anus is patent. Typically they're voiding and stooling, so that tells me that it's patent. But if this is a brand new baby, I'm going to assess then, or I can assess once they're on their back and I'm checking the diaper. So next I'm going to turn the infant over. And lastly, I'm going to look into the diaper. So as I mentioned, opening up the diaper, feeling the femoral pulses, and assessing the genitalia. If this is a female, I'm going to see if the genitalia are appropriate for gestational age. And if this is a male, I'm going to assess the testes. And then on both female and male, I'm looking at where the urethra is, and then the patent anus, as we mentioned. Thank you so much for your time.